So welcome everyone. For those that are attending live, if you did not hear, I just asked a couple things. One, share who you are, where you're from, and two, if you're familiar with the guide program or if you're not familiar. So we have a pretty, quite a few people are not familiar with it. So we will do a little overview, and then some of you guys are familiar with it. So we kind of have a mix. And as far as the recording, it will be available after the fact. But I am assuming, and you can correct me if I'm wrong, but everyone in here provides care to people with dementia, either some form or not. If you guys can share that, if you're already providing it, or maybe if you want to provide it or not. So but anyway, so the plan is I have a presentation that will go through. It will provide a brief overview of the guide program. We can provide you with more information or even previous sessions that we've done about the guide program. We'll talk about kind of some concerns we had with the program and discussions with CMS, and then information we have since received after meeting with them. And again, AOTA has been instrumental in assisting with this process. And OT is a key player in the guide program, as you'll see in a few different slides that I'll be sharing with you guys today. And I'd say Scott and Charmella that are on today that are more knowledgeable than I am on this will be able to help answer some questions. But because of them, we were able to meet with the actual people from CMS that are putting this all together. So huge reason why we really need to be members of AOTA, because we need to have this ability to be able to meet with people that are doing these programming. And I think once you guys see some of the outcomes from from the meeting we had with them and how it's impacting us, it's definitely a lot more favorable than what I was thinking was how it was gonna impact our practice. So again, we need more members, part of our national organization. So we will get started. Share my screen here. And I'm going to be going back and forth between a couple different screens so I can show you some information that they specifically put out with this. So again, I know there's more than just occupational therapy professionals that provide dementia care. And we have a lot in our next level groups, PTs and speech professionals. And hopefully you guys are on or watching the replay. And it's not that this doesn't impact you. A lot of this comes from AOTA's help and support. And I knew that Charmel and Scott were going to be on here. So that's why we're really doing a lot of focus with OT during this session. So a little bit about the guide program. So GUIDE stands for Guiding an Improved Dementia Experience. It's designed to enhance quality of care by improving quality of life for people with dementia and reducing burden and strain on their caregivers. The goal of the GUIDE program is to help reduce Medicare and Medicaid expenditures, primarily by preventing or delaying long-term nursing home stays, and secondarily by reducing hospital, emergency department, and post-acute care utilization. Now, this program is designed for community dwelling Medicare beneficiaries, including those that are dually eligible for Medicare and Medicaid. So when this program first came out, I think a lot of us were really excited about it because this is exactly who I serve, and many of us serve in our mobile hybrid practices working with older adults. We primarily work with community dwelling older adults Medicare beneficiaries, and many of us work primarily with clients with dementia and caregivers. So that's kind of the little blanket overview of the guide program, or basic description. It is an 8-year voluntary national model, and the performance period begins on July 1st, 2024 and ends June 30th. So, oops, I already have a typo. Applications were actually due January 30th. So the application, in order to apply to be kind of the primary participant in this program, you would have already have to done that by January 30th. So we're past that point, but there are still key things and ways that we can be involved with this, which is what we're going to talk about today. So the participant selection is taking place in spring of 2024. Participant agreements are due May, and then the guide model is supposed to start July of 2024. So in the beneficiary eligibility and alignment, and Scott, chime in whenever you feel the need here.
So I was just, maybe it's helpful for people to hear back in the general overview that the funding stream for the guide model is not directly through the Med B providers, like we would traditionally think of the funding stream. So technically, an outpatient OT practice would, even if you have a Medicare TIN, would not be eligible to be the funder, to be funded directly by the guide program. And that we were all a little bit verklempt, or that was a source of a sticking point, I think, for all of us, right? Was that so these codes, or these payments, go through a primary provider, NP, physician, PA, and it's their TIN that gets paid. But initially, in some of these programs, we were suggesting or thinking that OTs could partner, and that was one of the slides that Medicare showed, CMS showed, was the physician provider partnering with an OT practice to do this model. But you'd have to have a negotiated way of getting the funding from the physician to the outpatient practice. So again, that was a little bit of a sticking point, but I'm sure as we go on, you're going to hear why that's less of a concern today than it was when we started this process. So I will just leave it at that, but just sort of wanted to whet the appetite of folks who may be less familiar with the model about that.
Awesome. Yeah. And we'll talk about that, because I'm going to kind of talk about kind of even before we knew the changes and what led to us wanting to meet with CMS, and then kind of some updates that they had shared with us after our meeting with them. So yeah, for sure. So the guide model, like when you look at this beneficiary eligibility and alignment, community dwelling Medicare beneficiaries, diagnosis of dementia, Medicare primary payer, not residing in long-term nursing home, and not enrolled in hospice or PACE. So again, that's like who we work with every single day, right? So a lot of us, extremely excited about this. What you'll see on the next screen, my big push is helping therapists become outpatient hybrid practices where we work on this. So kind of redundant there. But this is where, like Scott said, brought up our issue, right? There was no option for outpatient hybrid practices that already have a program to actually be the main participant in this program. So that's what led to us kind of being frustrated. But I personally, as you'll see as we move forward, am happy with what we're going to be talking about today. Also wanted to give you a little background, especially for those of you that aren't familiar with the guide program. As part of the guide program, there has to be a comprehensive assessment. There has to be a care plan. There has to be 24/7 access to like a hotline. There has to be ongoing monitoring and support. There has to be referral and support coordination. There has to be caregiver support. There has to be medication management and care coordination and transition. So when we met with CMS, we specifically went over this slide with them, showing them that, you know, we think this guide program is doing, these awesome things, but we're already doing them, right? In our practice, we're already doing a comprehensive assessment. As an OT, we utilize the Skills to Care program. We do home assessments specifically for people with dementia and their caregivers. We work with the nurse practitioner who does the medical assessment. We work with the whole team for care planning. We coordinate with the Alzheimer's Association for the 24/7 access. We do ongoing monitoring and support because with my business, we do start with probably more restorative based, but then we transition to maintenance based through Medicare Part B. We work with a variety of agencies to provide caregiver support. Plus my business, we do provide caregivers through CNAs as well. I mean, we all know that OTs have a huge role in medication management and then that care coordination and transition. So when we met with them, we discussed this. And this was another concern when we met with CMS. We were concerned that the payment wasn't going to support us because we already, with what we're billing, would bring in more than what they're going to get through the guide program. So just to give you a basic overview, and I'll show you where you can read and get as much information as you want. The highest complexity for the first 6 months, they would only get like 360 with caregiver, 390 without. And then after the first 6 months, it drops down. And then there's the respite care payment that is also part of the program. So again, part of our concern. So we met with CMS. We talked about, the inability for mobile hybrid practices that already provide a more extensive care than the guide model to participate. We talked about our concerns with geriatricians and physicians, because that's a key player in the participant section, like what Scott played with the coding that they're billing through the guide model, and they're already burdened. We talked about the current healthcare system, reimbursement concerns. We talked about the data collection. We talked about, the inability to utilize great resources. We talked about home-based care for persons with dementia shown to produce better outcomes. We had all of these different things that we talked to them about. And then one of our biggest questions was, fine, so if we can't be the main provider or we can't be a participant of the guide program, can we still do what we're doing and bill for services for the people that are part of the guide program? Because that was another issue. So we met with them. They were awesome, very open to what we had. They had to say. They wanted to be able to ask additional questions and so forth with that. So now moving forward to where we're at now and how it's going to impact us. So just to review, providers eligible to be guide participants are, and I don't particularly think this is exactly from the guide model. This is what it talks about, and I'll show you a slide that really kind of breaks this out. But basically, we're not eligible to be a guide participant ourselves. And I'll show you a screen that shows this a little bit better so you guys can see. Share this. So these are the participants or the types of combinations that could have applied to be part of this program, our participant with the guide program. So a multi-specialty practice that, has a billing TIN, a community-based memory care clinic that also like partners with a primary care practice. They have all of these different ways that you could partner with someone in order to do this guide model. But what I like in this they did a webinar in January, and they showed that a participant needs to have partner organizations to work with. And that's where we really fit very well here. And they actually have this new slide that I don't believe, Scott and Shamela, you can correct me if I'm wrong, but prior, they didn't have this example in their prior really highlighted, but they showed how as an occupational therapy practice, we can be a partner organization to guide participants. So this is where we really need to be finding these people that are participating with the guide or who have applied to be guide participants. We want to be a partner organization with them. So that's where we can fit well. And we'll talk about this more in a little bit. So basically, say this geriatric practice, they have the billing TIN, they're going to have a geriatrician, and they're going to have a care navigator. They're going to be the ones that applied and are going to be a participant with the guide program. Now they want to partner, or CMS is encouraging them to have partner organizations. And that's where we're going to be able to play a key role. We're going to be able to be a partner organization with these guide programs. They're going to also want to partner with other people as well, like home health agencies that they highlighted. So we'll come back to this slide in a second. So even though, and I don't know if any of you guys are, were part of any organization or had anything to do with someone that applied to be a guide participant, you can let us know. But so where we're going to really come into is that we're going to be the one that wants to participate and work with these organizations. And that's where there's another slide that I want to share with you guys. That's where we're going to look in this. So they produced this strength and partnerships fact sheet. So my recommendation, and we'll talk about recommendations moving forward, but my recommendation is that you want to find out who in your area did apply, put in an application to be a participant, and then you want to try to be a partner with them. And this talks about, all the different types of partner organizations. And on this sheet, you can see that physical and occupational therapy practices are mentioned, that we can be partnering with guide participants. I think the language, so a participant is who actually has applied and is going to be a guide participant, but we can play a key role in being a partner with the participant. They should have had a different, not both starting with P's. So this sheet talks about, how these participants need to identify potential partners, right? They even give them tips on how you can engage with partners. And that's where we want to be on top of this, right? We want to be like, hey, we are dementia care experts in our area. We're already providing services to clients with dementia, to caregivers. We know all about the guide program, and we know that we fit really well with being a partner organization, and that's one of the requirements. And we can, in the future, we can kind of moving forward, hopefully kind of figure out ways to help you guys approach this. But even the better thing is that I was more excited about is the payment part of things, right? Because we were really concerned with, well, if people are part of the guide program, now we're not going to be able to bill what we normally bill. That was a huge question that we had. And so they clarified that payment design section of the RFA, which will highlight where the RFA is. It's like 70 pages, but they list the reimbursement rates for the different tiers, and they list all of the different codes that are to be billed through this program, and anything that's not on that list, we can still bill. So, and this is right from CMS's email back to me because I clarified it again, even though it does say this in the RFA and so forth, but partner organizations may continue to provide and bill Medicare for services that fall outside the scope of the guide model. So anything on table 8, we cannot bill, okay? Because that's part of the guide model. So you guys should notice that the only thing that really impacts us is the new caregiver training services. Which again, for my practice, we don't utilize these a ton because the caregiver is usually there when we're providing our services, and it's a big part of the services we provide is that caregiver education piece when the client's there. So we can continue to do what we've been doing and bill our OT evaluation, our therapeutic activity, our self-care codes. We can continue to do all of that for people that are part of the guide program. So I think I'm very happy with that. And I think that's huge. It's just that you're not going to be able to build this code because that wouldn't be covered because that is part of the guide program.
And just to connect the dots for people, if you haven't figured it out already based on this, right? The reason why the billing is going through that primary provider, that physician practice, is because most of those codes are considered what they consider E&M, evaluation and management codes, which we can't bill anyway, that only the physician practice can bill. So that's why the payment is directed there, because these are the codes that are impacted. And so they're going to continue to get reimbursement for the beneficiaries who are on their program, but they're going to be expected to provide these services without any additional billing. But as Kara clearly said, the only one that really impacts us is the caregiver training. So it really is good. It is really good news. And I think we had the impression that initially, if we were not included in an application, it would be impossible or difficult for us to be included in real life practice. But in fact, I think we believe the opposite almost, that now is the time to make sure your services, make sure the providers in your area are aware of the services you can and do provide, so that if they do become a participant, they know to call on you and to include you as they ramp up. That's the other thing, is that the performance year, the first year for most practices, is going to be a time to make sure they have their ducks in order and they have their program model in place, and they meet the requirements of the guide program. that's when we're going to have another window of activity where we need to be available to consult with practices so that they know they can count on us for comprehensive assessment, home assessment, and big pieces of the requirements. As Kara showed, a lot of those requirements have places for OT to feed into. So all is not lost. Do not lose hope if you have not, were not part of an initial application. There's still opportunity here.
Absolutely. And I would just add that this was a huge concern, as Scott said, for AOTA when we went in to speak with them. And we've met with them about 2 or 3 times now at CMMI. And I think it encouraged them to really look at this issue, which I don't know that was really considered before we started raising it. So if there is a need that's outside of these physician E&M codes where occupational therapy is viewed as medically necessary, I typically refer to our codes as a 97,000 series. So they start with the 97 and have 3 more digits after that. There are other codes outside of that, but generally those codes, other than, as Kara pointed out, these caregiver training services at the bottom here, those codes have been confirmed to be permitted to be billed to these, the beneficiaries in this program.
Table 8, when it talks about the Medicare fee schedule and the codes that are part of this program, also help to make sense why a practice like mine isn't going to be the main type of practice to apply to be a participant of the guide program, right? Because I mean, like Scott said, we don't bill any of these except for one. So I mean, that kind of helped clarify that, because I'm like, oh, well, yeah, those aren't part of it. So that did help clarify kind of my upsetness, like, well, why aren't we going to be the main one to participate and do this? Well, clearly what they're looking at with the codes are different than our OT and PT. But again, I think us being able to still have our own control over our private practice and the codes we currently bill, and being able to utilize those in our practice, as well as partner with a guide participant, I think is a win-win, because it allows me to really continue to do what we're doing with ours, but yet we also can work with these participants and show them how we can help them meet many of the guidelines, or requirements of their program, and all work together, and hopefully improve care coordination. So, moving forward. So, and I see there's been lots of questions on how do we find out who applied for this program? Well, I've just been asking. In our area, I do know one group that applied. So, that's where I've reached out and want to meet with them and talk about this and go through the information that we have available to us. So, just start getting out there and trying to figure out, if you can, who applied. Now, they won't even know if they've been accepted until they just say spring. And I think I put at the beginning, like, May is when the agreements need to be signed. So, after that, once a person is actually a participant, yeah, like Brianna said, they'll have a list of people that are actually participating. But I personally think you need to get above, and I think you need to get out there now and find out who actually applied, so you can get started before we actually know who already is accepted, is my viewpoint on it. And start those discussions on how you can become a partner organization. And then I think you need to embrace this. And because if I'm not wrong, Charmel and Scott, I mean, there's going to continue to be programs like the guide model, probably pushed out. And we need to start looking at alternative ways to partner and work with people that are utilizing these types of models in our practice. So again, embrace it, continue to provide the therapy services you are providing, and figure out a way that you can be one of the strategic partners with a participant organization.
So I think the key word that you mentioned, Kara, is alternate, these models, which are being sort of seeded, planted by CMS for alternative payment methods or payment models, really then become sort of templates for Medicare Advantage plans, for other private healthcare payers to pick up and say, we want to do this too. This makes sense to us. This is good care, good potential utilization of healthcare resources. So we're gonna move in this direction too. So just because the CMS model for this innovation demonstration is 8 years, that doesn't mean that in 3 years somebody else isn't going to roll something similar out. And so, again, I think we have to be creative about how we think about responding to these alternative models. I don't know if anybody else is like me, but we don't like change. I know what I do it this way, and it works for me. So don't upset the apple cart. But the reality is that we have to get a little bit more, I think, flexible and creative about responding to these. And that's the other thing that to just underscore with this, because this is a demonstration project, they're gonna learn things on an ongoing basis about, and it may be, and I'm just sort of spitballing, but sort of best case scenario, right? It may be that through this process, they find that the best outcomes are from practices that have partnered with occupational therapy. And then that's going to lead to the definition of a model that includes occupational therapy very clearly and very upfront, which is not the case in this model, right? So again, that's why we see there's some level of urgency from AOTA's advocacy side to make sure that people are thinking about this as, yes, this is an opportunity for me right now, but it has bigger implications for the field and for the quality of dementia care in this case, for a long time. So don't think of this as it either fits or it doesn't fit, but stay tuned and stay involved. And even if you're not practicing or participating or partnering directly, I think it's worth keeping abreast of what's going on and keeping in touch with people who are practicing, because it's gonna, I think we know enough now to know that this is the direction that a lot of healthcare reimbursement is going to be heading in.
Yeah, absolutely. And I think Scott said it very well. And the only thing I'd add is that to that exact question, I think Constant asked about Medicare Advantage. So no, it is not currently applicable to Medicare Advantage plans. In the slide deck that Kara shared, which I can also put in the chat, if you go to I think it's slide 14, it tells you who are eligible beneficiaries, and they must be enrolled in traditional Medicare Parts A and B. They must have a dementia diagnosis, not be residing in a long-term nursing home, not be on Medicare hospice, and not enrolled in a PACE program. And so there are some parameters as you dig deeper into those slides to know about. And as Scott said, the idea here is to really test this model with the traditional Medicare beneficiary population, so that in our best case scenario, I know for myself and Scott, best case scenario would be this gets implemented as a mandatory benefit as part of Medicare in 8 years, and then is adopted by Medicare Advantage plans and Medicaid plans, and perhaps even sees some benefits in the commercial payer world.
Just wanted to highlight here, and I put this in the chat. So this is the RFA. And again, on page 11, they talk about that they will need to have partnering organizations. And again, on page 12, they show examples, which again, they highlight an occupational therapy practice, which I personally am very proud of and think it's pretty awesome that, they're highlighting OT private practices here as a partner organization. So, and then when you go through this more on page 24, I think it is 23, these are all of the different services that must be provided, which I kind of highlighted on that slide earlier. So there's a lot more detail, 70 some pages in here that go through the guide, model. So other questions that you guys have, does anyone, and maybe you already said this, but does anyone in here already have a relationship with someone that did apply to be a guide participant?
So I will say someone, and I forget the name off the top of my head, someone mentioned that the providers that they work with are in their community are more affiliated with health systems. But interestingly, each individual TIN, so if I'm a physician, even if I work for a healthcare organization, that organization typically bills against my individual TIN for the services that I provide under the Medicare fee schedule. So my TIN, so the way I understand it is that even in a healthcare system, they're going to have almost have sub-applications for all the individual TINs. So again, if I work for a healthcare system, but I work as a geriatrician, maybe there are 4 of us who are geriatricians who see a lot of dementia cases. It's going to be the healthcare system application, but then sub-applications individually for each of the 4 TINs. That may become important because some people in that organization may do more community-based service provision. And so those are the people who may be less sort of medically attached to the health system and may see the benefit of working with folks who are more boots on the ground in the community. So again, I think there's lots of sort of layers and creativity to this. And this is where demonstration projects are kind of cool because the models that folks can develop, like going to a health system and saying, hey, is anybody doing this? Would you consider partnering? I have a specialty in dementia care. Your OT department doesn't specialize in dementia care, but I have this outpatient practice that does. Maybe we should be partnering together. Maybe there's an opportunity here for you to get the needs of this population met in the best way. So again, there's creativity abounds in this demonstration opportunity for folks. We're only restricted by sort of our level of creativity in this.
We had a couple of questions. Just to clarify, if a patient family is not participating in the guide program, mobile hybrid private practice can still bill caregiver education without patient present, which yes, you can, but I also like to highlight because I hear a lot of misinformation out there still about the new codes. We can't bill that code by telehealth, those codes by telehealth. Not that you were asking that, but I just highlighting. Can you remind me when they will select the providers and will that be published? So they're supposed to be done by the end of May, and then they said, I think June is when they're looking at providing the list of people that are actually participating. And yeah, Constance, I'd be interested to know, like, because like an area agency on aging in a memory care support program with a federal grant, that'd be interesting to see how they were able to participate or to be a participant with the requirements. Any other questions that you guys have? Scott, Sharmella, anything else that?
I think we've covered a great deal of it. And as Scott also said, and Kara said, you know, we would love for those of you who feel you meet these criteria, you know, getting involved, trying to talk to your geriatricians. For the folks who have said they're not sure if, you know, their home health agency is participating, ask your administrators, you know, if, and try and as you are doing, try and find out. And if not, it might be something to really look at. So I think that's all I would encourage right now.
Okay, so Abby had a question. So just to clarify for us, if our patient is a dementia caregiver, we cannot bill for caregiver ed provided to them unless we apply to be part of the program. So no, let's talk about caregiver education. So if you are a private practice OT and you're working with clients with dementia and providing caregiver education, many of the times you're billing based on what that caregiver education is. So whether it's self-care CPT code, therapeutic education CPT code, and so forth, because the caregiver and the client are both present. So we would, whether they're in the guide program or not, we can bill for those services. The new caregiver education codes that came out are specifically for caregiver education when the client is not present. But that does not include telehealth. We cannot bill those new caregiver codes if they are part of the guide program, because that is part of the guide program. Abby, can you let me know if that answered your question?
The other piece, which may be related but may not be related, is that it's really important to sort of, as we talk about this guide program, to understand that when we use the term participant, we're using the term to describe the physician practice who gets paid. When we're talking about clients, they are the beneficiaries in this program, right? So they have the voluntary option to, as a beneficiary, the practice needs to offer them the opportunity to participate, but they can decline to participate. If they decline to participate, they're not, you know, all bets are off, right? There's no guardrails in terms of this program. So we're only talking about the caregiver codes being influenced if the person is a beneficiary under the guide program. And then it would be a requirement that you not be able to bill those codes. Now, providing that kind of education, if you partnered with the provider, the education, they might agree to, you know, pay you on a monthly basis a portion of their fees, you know, their payment, because you're going to provide all of the caregiver education for the cohort of individuals that are beneficiaries to that program. But that's a different model, right? You have to sort that out. That's why it's sort of unclear, and it's sort of, this is where the creativity comes in. I may be able to partner and get some reimbursement for contributing to part of that comprehensive assessment and evaluation. I may be able to get some reimbursement for participating in some of the care planning activities, and I may get some reimbursement for participating in some of the caregiver education stuff in the beneficiaries who are enrolled in the guide program. But other than that, sort of you can bill your regular fee for service codes as you would normally.
A couple questions. Abby said sometimes the referrals we receive are not for the patient with dementia, but rather their spouse who is caring for them, who is experiencing mental health quality of life changes. So that is many, or as
So,
well, we see several of those clients.
but if they're your client, it's their medical insurance that's being, if they're the identified client, you're using their Medicare, not the person with dementia's Medicare. So that becomes really important, I think. If you get a referral for me, I'm taking care of my wife and I'm distressed and my ADLs and my self-care are starting to fall apart, and the provider says, hey, Scott needs some support. Can you get in there and do an evaluation, see what we can help him with? That's a very different referral than, hi, this is Scott's wife, and you're treating her, and you're providing Scott with a little bit of information along the way. That's a very different model, right?
Yeah. A lot of the two, though, go together, right? I mean, a lot of times there's something going on with the client with dementia, and we need to look at, I mean, that's a whole different side ball game, but we need to look at the caregiver, the client, the environment, and what's going on that is most likely leading to this caregiver stress and so forth in there. So and let's see, Sharmella answered the telehealth codes. Okay, awesome. Yeah, again, the caregiver codes make a ton of sense if we could do it telehealth. It's just not quite there yet. So hopefully you guys can get that pushed through sooner than later. Any
Yeah,
other
we're actually
questions?
already on it. There was an opportunity to add new codes for the fiscal year 2025 physician fee schedule. So for Part B billing, and we put them in anyway, but the likelihood is very low. They like to collect data for some time. So we will stay on top of it.
Yeah, awesome. So again, oh, can you talk about the
Incident to,
AOTA, Inspire and so forth and things coming up?
Sure. Well, I'll take incident to billing first. Yes, there is still the ability to do incident to billing. Maybe I would love to, if you want to put in the chat here more about if this is in reference to the guide model, because still those 97 that are typical codes that are billed would not be permitted to be billed under that model. But yes, incident to billing in general is still an option. It's not utilized very frequently, and to my understanding, as it used to be many, many years ago. And then in terms of, I didn't see the question, but in general, in terms of Inspire, I think the question is what AOTA is doing. So Inspire is in Orlando, Florida this year, the week of, help me out here, Scott, March 20th through the 24th.
right.
And we will be there as staff. We have several staff sessions that will talk from the policy side. We're going to be handling federal regulatory advocacy under Medicare. We're having a private practice reimbursement town hall for 3 hours. It's a workshop on the Friday. Happy to share more information as we get there. A CPT coding overview will be happening, and there's also a documentation workshop. And I know Kara has several workshops focused on private practice as well that she can share, and Scott, I will let him share from the practice side, but we'll be there. We hope you'll join us, and we'll be busy and happy to see you.
Yeah, from the practice side, there's lots of content that would be dementia specific or geriatric productive aging specific, that you should be on the lookout for in terms of conference sessions. Additionally, we will be in the AOTA experience section in the exhibit hall, to answer questions and to sort of inform people about practice resources that we have and information that we would love to be able to have everyone know about and to be able to access, because we have lots of resources and then we kind of hear, oh, gee, I wish I had known you had that, because so people have difficulty finding stuff on websites, and that's the nature of the beast. So check in with us if you have questions. We'll be in that area pretty much throughout the conference times. And we, as Sharmila said, we would love to talk to folks and hear more about your questions and concerns.
Yeah, and we will, we're gonna have a next level OT booth. I'm excited at the expo, and we are doing presentations for private practice. There's a whole day one on the first day on Thursday. We also have a spot to stay in. We have a couple more rooms available for people that are looking to share a space to stay at AOTA that will help reduce your cost. And we're gonna have a couple meetups as well. So we'd love to meet and see everyone that is going to be coming there as well. So excited. Thank you guys for joining. Again, if you can help spread the word to other people in the OT world with dementia care, because there's a lot of misinformation, people not understanding things. This is a great time for OT really to showcase what we can do. I see that in the attendees, there's a lot of home mods therapists on. Again, you guys have a big role in this. I mean, this is a big piece by really showcasing how you can be a part, even if all you do is the home mod piece. So lots of great ways and opportunities for us. So continue to advocate, and remember to join AOTA. They don't tell me to say that anyways. I'm just showcasing, because we wouldn't be here today if it wasn't for them. So thanks, guys. Appreciate it. And reach out if you have any additional concerns. Sharmila and Scott, thank you for popping in and joining us today. Appreciate it. Bye, everyone.
Thank you. Bye-bye.